Welcome to the Healing Health Podcast. I'm Amber Petty. In this episode, I'll be talking to Professor Tracey Bucknall from Deakin University's Institute for Health Transformation. We sat down to discuss her research into how we can make Australian hospitals safer. So join us in the conversation now. Well, Tracey, thank you for taking the time out this morning. It sounds like you've had a very busy morning juggling all parts of your life. I'm looking forward to talking to you about all of your roles and research in medical emergencies and patient safety. This seems to be a subject that's a little bit easier to present to a layperson like me. So thanks for being here.
Thank you for having me.
So I just want to read you a little something and you can tell me whether that's been plucked from nowhere or whether it has some merit. But I read in Australia, 11 million people are admitted to hospital each year. And of those 11 million, 1 in every 10 patients suffer some kind of harm that's not related to why they went into hospital. And a staggering 25% of an Australian study, so I'm doing little quotation marks there, 25% of those patients ended up permanently disabled. Is any of that right?
That's all statistics from research.
Wow.
So the Australian Institute of Health and Welfare published a report, and from 2016-2017 there were 11 million hospitalised patients, hospital admissions.
Yeah.
So that's where that figure comes from.
Okay, yep.
The 25% comes from a study that was conducted and published in the 90s. So we're going back quite a way.
Yeah.
But that study was a replication of studies in other parts of the world, and the figure came out really consistently across all over the world, 10% of patients. So if you think of the that's more than 1 million patients who are being harmed during their hospitalisation. So, and it's unrelated to their disease.
How does that, I mean, that is a staggering amount of people, and that the thought that I could be in the quarter of people that go in for whatever it is and end up permanently disabled. But what sort of disability and what am I going in with and potentially coming out with in this sort of...
So an example of harm that might occur is perhaps an elderly patient who's living quite well at home but goes in for some elective surgery. They need a hip replacement.
Right.
And whilst they're in hospital, they actually have a fall.
Yeah.
And it might be because they're elderly and they needed to get to the bathroom quickly.
Higher beds or different...
Higher beds.
Surroundings.
Not on carpeted floor, in an unknown area, poor lighting... the things that are quite foreign in a hospital environment become actually barriers for
obstacles.
People. So with these sorts of people, they need to go on and have a hip replacement, perhaps because, they suffer a fracture from falling and need to have some further surgery. Those patients sometimes don't actually, because if they're elderly, they become more immobile from having that fall. They may not be able to return home. They might go through a period of going for transitioning to a rehabilitation place, but then it may be decided that they're too frail to go home, so they'll end up in residential aged care. And, that they might then be always on a walker. They might always have suffered a shoulder injury, perhaps from their fall if they've broken their arm, that they just never regain their mobility that they had previously.
Okay, so that's
the type of permanent disability.
So that makes sense that elderly people in environments where it's that they've suffered something, so they are weakened, but they're also not in their own home environment, as you said, lino versus carpet, different things. Would that make up a fairly large percentage of the 25%? Because of course, I've gone into drama mode and thought, what? Like I'm going in to get my tonsils out and I'm coming out, with a permanently, I've broken my arm and it's permanently, it's never the same or something like that,
That does make up a number of them, but there's also other things, and you would have heard of infections, hospital infections.
Yes.
That's another thing. So these hospital infections can cause major breakdowns of wounds. So, for example, even any skin lesion any break in the skin can turn into a major wound in a hospital because of becoming infected. So
I see.
There's other things such as pressure injuries, which we used to call bed sores. You've probably heard that term.
Yeah.
And bed sores come from people being immobilised and lying in bed and not moving around. And so they get these sores that break down, they get bigger and bigger, they require skin grafts. You can imagine the sequelae of things that they need to have further treatments, longer stays, high costs, and they're never the same. They're the sorts of things when we say, permanently disabled. It's not the disabled that you're in a wheelchair or anything, but you have some level of disability because of what's been encountered.
Okay, gotcha. That makes sense. But
we do have lesser things that go on.
Yeah.
For example, a medical error can be something as common as a missed medication. So the person comes in and they're having treatments and they miss particular types of medications because someone's may have forgotten to give it.
Yeah.
It may be that they could be given the wrong medication.
Yes. And actually in this series I talked to Martin Henscher about his research into over-medicating, over-treatment, and of course the harm that can come through being prescribed something that wasn't right for you and the symptoms that occur from that, which is really fascinating as well. So that also, so moving out of the 25% where I've gone, people, 1 in 10 patients suffering from harm in hospital that shouldn't have really happened. So it can be something like that.
I mean, the harm can be lesser.
Yes.
But on average, it causes a length of stay of another 7 days for everybody on average.
Yeah.
It does blow out the costs. And given that we have such a shortage of hospital beds, we have a backlog of waiting lists for people wanting elective surgery in public hospitals, these types of safety issues really need addressing. And quite often you see them as front page news as a coronial inquest. And you see families who are, it's not just the cost, the economic cost, but it's the personal costs to families and communities of losing someone or having this sort of error occur.
Yeah. Yes, it's at the higher end. It's incredibly traumatising and obviously costly, especially when it gets through the court systems. So let's talk about your research specifically in the area of medical emergencies and patient safety. So what's the purpose of your research and what is the process of you actually finding the data and information that you need?
So I'll give you a little bit of a background in how I got to where we
yes,
have
please.
Got. So in these statistics that we've just talked about, there was a key statistic that showed that a lot of patients who were suffering these disabilities or were dying were in hospital at the time and were having delayed treatments or delayed diagnoses because they, instead of getting on the trajectory of getting better, they started to deteriorate. And so in that deterioration, you're trying to, the clinical staff, the nurses and the medical staff that are in hospitals are trying to recognise that change from going in the right direction to going in the wrong direction.
Yes.
And they need to be able to recognise when that happens as early as possible.
What's the tipping point?
Exactly. And so when I started my nursing many, many years ago, we used to have to wait for someone who actually stopped breathing to get assistance from the intensive care unit to come down and assist with the patients. Whereas the studies, all the research has been showing that the earlier that it's recognised that these patients have started to go backwards instead of forwards, that we can actually reverse it and keep them on the same trajectory so they're going to go home in the same time.
Right.
So What we've done now is through a whole lot of measures that are new accreditation standards for hospitals, focusing on patient safety in all the areas that we've already talked about. We've now got standards where we have it mandated that there is a response system in place, an organisational response of different levels, so the sicker someone becomes, a different group come in to assist. And by that, I mean, so normally in a hospital you have a medical consultant and some more junior medical staff looking after you, and the ward nursing staff. In the situation when someone really gets to a tipping point where we know that if we let them go any further, they'll end up in intensive care or perhaps even die. We need to see them, treat them with this really in this time critical point by these external people coming in, usually from in the intensive care unit, to treat them and prevent them from becoming sicker. When we do that, we know that between 80 and 90% of patients can then stay on the ward. There will still be some that end up going to intensive care, but most can be reversed and stay on the ward.
So how does that work though? So, you've got a busy ward, 4 patients in a room, the normal staff going in and out, the specialist head doctor coming in like once a day or every second day or whatever it is, and one or all of those people in the beds are all suffering and sort of waiting for their attention. Is it so? It's, I would presume, the nursing staff that are trained now to recognise what are the cries for help or the changes that they then say, okay, we're now allowed to call in the intensive care nurses above us.
So we used to not have that facility. Now we have that facility. There's special numbers that we call and alert the team from intensive care to come down.
So does that mean we've got more intensive care nurses in the hospital system now?
No.
Oh, gosh.
But what we have special staff who are rostered to go to these patients that need to be seen by the medical. It's called a medical emergency team, and so there's specialists that are usually rostered to go out and do that. That's not always the case in some hospitals, and you can imagine there's quite a variability from a rural and regional hospital through to a place like the Alfred, where I work as a nurse, and that extreme where they've got a bigger intensive care unit, more staff, and so forth. So from the patients that actually deteriorate, there are criteria that nurses are looking for.
Yeah, what is that?
So they're areas. Every nurse, and for years and years, forever, have been taking vital signs. And by vital signs, I mean measuring someone's pulse, how they're breathing, looking at their temperature, measuring their blood pressure. So we know that these signs, that if we get changes in these signs, there's a threshold outside the normal range that when they get into that we need to assess them further, intervene, or refer them on to this team that needs to come in and do a more critical type of analysis and diagnosis and treatments than what the ward staff have available to them. So there's definitely different equipment that might be required to get a clearer diagnosis. For example, treatments that may not be able to be given on the ward that have to be given in intensive care. So, but there are criteria, these medical emergency call criteria, and we work within those. And this is what the standards from the Australian Commission of Safety and Quality in Healthcare have for accrediting hospitals. Now we have these criteria put in place. So nurses work within that, in their scope of practice. By that I mean what they're allowed to do before and what they have to ask for prescriptions from medical staff. For perhaps putting in an intravenous line, giving
for going up
fluids.
Upping their level of
that's
treatment.
That's exactly right. So they will do what they can do, and then they'll escalate it to someone else to come in and assist and be able to make decisions that are different from nursing decisions.
Do you know, I realise now that you're speaking that I saw that happen in actually a really I don't know whether beautiful is the word, but seamless way was last year when my dad died on Good Friday, and so his heart was failing, and it all happened so quickly. But it went from a situation where I was told that he might have 3 to 6 months left, and then he was dead in 4 days. And what happened that was interesting, because of course I'm in la la land. I'm like, what is happening? I mean, it was just, I felt like I'd been hit by a truck. So I'm not very good with going, now what do I need to be looking out for here? Because I also didn't realise, within a 24-hour space of time, I didn't realise how much it was escalating. So that was all in the hands of the people that you're talking about. And I don't know that in 24 hours they realised he probably wouldn't see it through Easter. And so what happened was he was in a shared ward, a public ward, and, I'm so busy with, I'm having to tell people to come and sort of say goodbye type of thing. And so the normal nursing staff are doing whatever they're doing, but then suddenly, within a fairly short space of time, we were now being taken into a room on our own, which in the scheme of things was a beautiful room because it literally had a very big window and it looked out to over the Melbourne Exhibition building. And actually on the night that he died, it was the most beautiful pink sky. It was absolutely extraordinary. This is at St Vincent's, and this incredible nurse whispered in my dad's ear, look out the window. She moved his whole bed and said, look out the window and, take this image on your journey with you. It was honestly, oh my God, are you crying? Oh, you're crying. I thought, am I going to tell this story because I don't want to cry?
Yeah.
Her name was Grace, just to top it all off, this nurse. She was unbelievable.
So one of the studies we've just completed, we interviewed patients and families after they'd experienced this period of having serious deterioration.
Yes.
And the medical emergency team coming in to visit them. And we studied this at public and private hospital.
Yeah.
And what we found was there's patients themselves have a sense of something, and it's not impending doom or anything like we hear in, stories and on television. But they do feel something's not right.
Yes.
And that
Dad kept saying that. That's exactly what Dad he quickly couldn't talk, but leading up to it, he said something's not right.
So that's exactly how people... So what our study has really shown is that there is... we have physical symptoms which can be measured by taking vital signs and doing, things, X-rays and things like that. But there's visceral feelings.
Yeah, explain visceral.
So they're the things that they're not something anyone else can see, but it's a sense of something, a feeling. And those family members can have them as well, because
there's a connection. I guess it's a
the behaviours that your family member normally does.
The signs, expressions.
So for people, we often hear people are normally stoic, so they won't talk about their pain. But when they do say, I'm in severe pain, that it really is.
That's right. They don't say this. This
way
is
worse than normal. So that's the sort of thing, and those are the stories. So I've had a PhD student analysing those stories and looking at what are the things can we learn from those stories in order to perhaps work with family members and patients when they come into hospital. And I'll give you an example. When you go to the airport and you get on a plane, before we take off and go down the runway, we have the stewardess or steward doing the safety talk.
Yeah.
They show you where to get the oxygen mask coming down, where the exit rows are, and all of that sort of thing. So when we started this study, it was really on the basis of what information could we give patients and families to prepare them when they arrive in hospital, that if they get these feelings and things, because there's more
when
and more...
someone is really, really sick.
Yes, when we know more and more through our research that the earlier that these subtle signs are picked up and that someone then really monitors them very closely, the more likely we are to prevent them having that really extreme deterioration and something bad happen and harming someone.
Yes.
So we do want the patients and the family members to actually express to nursing staff are the ones that are most close to the patient.
Yeah.
They get to know them, they look after them for a period of time. So tend to have a stronger relationship and more of a rapport, but also it's the language, as we've mentioned earlier, about how the translations that nurses do between doctors and patients sometimes. So speaking in lay language, but we wanting to hear what patients and families are feeling in order to make some decisions about, do we need to do further assessments? Do we need to intervene from a nursing practice level? Or do we need to, what we say is escalate to someone such as a medical practitioner who can prescribe different medications or send someone off for x-rays or scans or something like that. So those stories are actually, we are recognising now it's more and more important to listen to those stories.
And also giving, patients' loved ones permission to be able to sharing those, because I think everyone's got a different level of, when they're in an environment like the hospital, like it's not a competition about who loves their loved one more, but there is definitely, I think, going to be different levels of when do I bother the hospital staff, because I can see they're looking after this person and this person. And, in the example of my dad, one of the poor young people in the room, well, it was the only young person in the room out of 4, I think was maybe a heroin addict or something. So looked to be really, really suffering. And of course, I'm not realising how much my dad is suffering. So there's lots of just little moments where you think, thank God St Vincent's nailed it in terms of, everything that they did. But I did sit back, I'm sure, and go, is that normal that he just vomited up his orange juice? Like, should he be that, things like that?
I think that's the important part, and that's why aeroplanes and the airline industry have done this so well in you preparing, what to expect.
Yeah, and just hammering it home over and over again,
That was part of our research because people expect to be sick in hospital, so when they get starting to feel worse, some people just think, well, that's what I'm here, I've had surgery, of course I'm going to have pain.
And it's okay,
even if I get more and more pain, I'm expecting to have pain. Whereas actually what we need to be able to do is talk to them about what it is with pain. For example, when you've had surgery 4 days earlier, you shouldn't expect to suddenly get a different type of pain.
Right.
Or a pain that was you've had your hip replaced, but suddenly you've got chest pain.
Yes.
So we need to know differences.
Yes.
So part of it is the conversation that an admitting nurse, and by admitting nurse I mean the nurse who receives the patient when they first come to the ward, has a conversation with the patient and the family members about, you might expect this is the way things go, but sometimes it doesn't always go that way, and we need to know if it's not heading in the right direction. And these are the things you might, if you experience these, we need to know about it. And then that opens up the conversation. And we know from other research that when we give people permission to express their concerns, there's earlier recognition and a quicker response, and then a prevention of harm.
Wow. So what are some of the other kind of areas or aspects of your research that you're showing, that are showing up for you?
So we've been working quite closely with how to assist nurses to have this earlier recognition. And, you touched on one of the points about when there's a lot of nurses around, but they're all looking really busy. What do you do? And I think that's the point where we have to, and this is why research is so good, because it allows us to reflect on what is going on, look at analyse the data, see what areas are where we're having delays, where we're not having, where things are working well, where they're not working well. And what we do is then target interventions or strategies towards, it might be educating staff, particularly in an area, or it might be giving them more information in order to make decisions. Because what we know, there's a lot of noise with information now. Nurses are dealing with incomplete information, too much information. The environment of a hospital is so busy, so noisy. We know patients don't get very much sleep, and it's the same for
that's a
clinicians
part of it.
And all health professionals all have so much noise going on around them. People are being interrupted in their interruptions. They go to interrupt someone, and someone will interrupt them. And so and that breaks someone's concentration and decision making. And we are making life and death decisions about whether to intervene in some way or treat someone in a way. So if you've got the decision making sort of broken, that concentration broken because of all the things going on around you, then it's really difficult to ensure that the system is fail-safe. But what we're trying to do is build a fail-safe system. So one of the areas, for instance, we were trying to work out, this is one of the studies, we were looking at all the patients that were discharged from intensive care at the Alfred Hospital, and we studied who of those went on to have these medical emergencies, and could we identify them on the discharge from intensive care so they got more support, so they didn't end up having these medical emergencies.
Meaning they had to come back.
And having to come back into the intensive care. So we were trying to prevent that. So one of my honours students who was doing a Bachelor of Nursing had an IT background, and she was able to link 4 different databases from within the hospital, so we could actually then run some statistical modelling where we could actually predict who of these patients who, when they are leaving intensive care, are most at risk of having these medical emergencies. So the system is that then the medical consultants, the ICU consultants, so those that have got special intensive care training, actually go and see those patients that are most at risk, and then they keep an eye on them, so they're not going to just tip into that balance of being, deteriorating and not being recognised, but they're being monitored closely. And those that aren't at risk of having this rebound, based on the model, can be seen by their regular physicians in the wards as they normally would. Because it's a workload issue. You can't concentrate when you're, the Alfred intensive care is over 50 beds now in size. You can't physically see that many people and give a really concentrated view if you've already looking after people in the intensive care to go out. So there are, it's a workload issue, but it's making sure that the right people see the person at the right time to make the right decisions.
How will you change tomorrow? Design a future beyond your own. Design a future that makes a difference. Deakin's research students are the best and the brightest, with access to global leading researchers, world-class facilities, industry partnerships, and innovative research centres, designing cutting-edge solutions that make an impact. Become a change maker. Become a Deakin research student. To discover more, go to deakin.edu.au/research. Deakin, more than a university.
What I'm also interested in with this series, and I think other people listening will be too, is not just literally the research that you do, but what motivates you to be in this area. Like, there's obviously something about what you do and who you are as a person that is just so passionate and, about your area.
If I think back why I became a nurse, it was probably... People always recognised that I was a caring person. So at that stage, I'm old enough that, there were limited opportunities for what sort of career path you took. And I did like caring for people. So I ended up going and doing my hospital training.
How old were you when you did that?
I started when I was 17. And that was, I had grown up in the country on a farm. I had never seen the likes of the sickness that I saw as soon as I started at Royal Melbourne Hospital.
Wow, that's a baptism by fire, isn't it?
It was, and I had grown. I was in an all-female family.
Oh, really?
And I'd gone to a girls' boarding school.
Oh, gosh.
Then I went and did nursing and lived in a nurse's home for the first 9 months, where it was all females, and there was one floor of male nurses, and that was half empty anyway, as you understand, with such a small number of male nurses, although we have more now.
Yes.
But I think, when I quickly in my training, I really liked the technology and understanding. I really focused on how could we improve what we were doing. And I ended up in intensive care, and I would look after one patient as an intensive care nurse. And, I knew that I was doing that to the best of my ability, and I would go home and I'd feel, happy with that. But then I thought, well, I only ever care for one patient, one shift, 5 times a week. There's not a lot of people that I can change, improve their care.
You want to impact more people.
Yeah, so I was lucky enough to be able to get a couple of scholarships, and I went off and did my degree, and then I started educating. I had a lecturer's position. I was able to educate nurses, and I'd be standing in a lecture theatre as we did then, and you might have 400 nurses in front of you, and
be careful what you wish for.
Yeah. Yes, but, at that point I really loved it, and I thought, oh, well, I'm impacting.
Right.
This is going out, this is a larger number of people. So if I do the right thing...
My help is going viral here.
Yes. If I do the right thing, then I'm able to actually expand this group of patients that I really wanted to improve the care of. And that was really going well. And then I started doing research, and I really thought about, well, when I'm doing my education, I might go off and do small groups or large lectures, but it's who you actually interact with. You're limited by your interaction. But with research, your interaction is possible to reach the whole world. So publishing in international journals, going to international conferences, doing podcasts, doing social media, having followers on Twitter. You're able to spread the message, and hopefully that
big
message
ripple effect
has a wider audience and able to make a difference. And I think my philosophy has always been focused on improving care. So when I'm designing something, I always have that front and centre. If I can't see a pragmatic reason for doing some research, then I don't do it. It's got to have an end point of improving care. And I started studying how people make decisions, because there is a belief if you understand how people make decisions, then you may well be able to improve them. And the recognition and response of clinical deterioration of patients in hospitals is one of those things, because of as I said, the noise and the environment that nurses are working in. It's very easy to miss those subtle cues.
Of course.
So in decision making, we need to then put in systems that perhaps make it impossible to ignore those cues. So what can we do that will make it fail-safe system?
And what do you think, have you had feedback in terms of like some of what those are in terms of the nurses, like what's been most helpful? Like what do they fear the most, or feel, I guess, what's a sort of element of their job in terms of what we've been talking about where they feel most sort of nervous, like they're not hitting the mark, I guess?
Look, I think there's been a lot of socialisation of nurses in the past that's been very hierarchical, related to medical doctors, working with nurses, but it's also the gender issue of males and females. So in a lot of organisations, the structures are determined by medical staff, and so we need to be able to put in organisational changes that recognise the contribution to decision making of other people,
the collective,
with the due respect shown. And in the deterioration area, we used to just have it around vital signs. And so until a patient had abnormal vital signs, so their heart rate was racing or their breathing had slowed down to virtually nothing, we could then call the medical staff and say, we need to intervene here. But we had to wait till those signs were showing. Now we can call in the assistance by saying, I'm concerned about this patient. So it's a respect, and the concern is based on those subtle things. I'm worried because I don't think they're right. There's a subtle change. They might have had, suddenly they starting to show some confusion in their speech. They're not sure where they are anymore, but they've always known for the week before, they've always known that they're in hospital and what day it is, and suddenly they're confused. They don't know where they are. It's really important for people to understand it's fabulous to be in hospital and have a really caring nurse. But it's equally as important to have a nurse that can intellectually analyse what is going on with that patient, to pick up those subtle cues and to intervene and make a difference.
To be educated and also intuition.
And mind.
Yeah, that's right. And I think the heart is really where probably the intuition comes from, where it's like...
So the intuition is a really interesting point because we talk about female intuition.
Yes.
And a lot of nurses talk about having gut feelings.
That's right, which is intuition, because that's really, I think, where...
But they don't get that from being a female or being a layperson. They get that because they've had repeated exposure to events and patients deteriorating, or, groups of patients that have had the same diagnosis and how they then proceed with their trajectory of illness.
Right.
So they get it from repeated exposure. So all of a sudden they've had so much exposure that it becomes their routine way of they unconsciously are taking in information and then making decisions. Whereas when you come across something that's very unusual, even with a patient that's had the same, still had perhaps admission because of a cardiac reason or heart attack, they can still present differently, and that will slow down someone's decision making, and they will have to bring in more information in order to analyse it to make the correct decision of how to proceed. So the heart, I always like to think of the heart as the kindness part of it.
The kindness part?
Yes. It's where you show empathy, the emotional intelligence of something that's going on.
And truth. And
yes, and then trying to, look after someone as you would like to be looked after, or your father was looked after. That's the way people come into hospital. They, if the people talk about their experience, is often based on the caring aspect that they get.
Yes.
But you can have a very, very caring nurse who makes the mistakes. So it's important to have...
Of course, we're humans.
Yes, but the mistakes, if they're not putting the jigsaw pieces together, that could have detrimental consequences for someone. So it is important to have both the heart, the kindness, the empathy, but also the mind, the intellect, the decision-making, the critical thinking that can recognise, assimilate information, and then make a decision on how to proceed.
But also the blend of the two. And
exactly.
How do you, as you said before, in the past there's been issues with sort of gender hierarchy and all that sort of stuff, and I guess in people feeling empowered to sort of share the information that you're saying, your research is saying, we need to, on both sides of the fence, patient and health professional, be able to recognise and speak up. If I'm a nurse, I'm on the basic level of, there's always going to be a hierarchy as such, but hopefully a more positive one these days. If I then need to go to my next up, and all I've got is my gut tells me something's escalating here, but I can't pinpoint an example that's related to vital signs, is my senior now going to be, or do they need to be more educated to say, I accept what you're saying. I don't think you'd step forward if you didn't feel something, even though I don't have the facts to back that up. It's literally my instinct.
So that's a really interesting question, because we know that when people have good relationships, the team have good relationships.
Yeah. Communication.
I would know that if Amber came to me, Tracey, and said, I'm worried about this person, I do know how you practice and that you wouldn't come to me unless there was something that was happening.
Yes.
My response would be, okay, let's go and look at the patient and review that. But also it's from my experience, I can then say to you, okay, so what sort of things are you noticing, and try and draw out what it is that you've noticed.
Articulate why I've come to that conclusion. There will be things. There'll be something.
There will be something. So it might be, look, Amber's become very ruddy in the face,
yes.
Flushed. She's getting warm, but I've taken her temperature and it's not yet abnormal.
Yeah.
But I can see something's not right.
Yes.
Or it might be that, the person starts slurring their speech, or some of those little things. So the person that you've gone to should be able to go back should go back and assess with you,
but try
and work it out. And I think if nurses are aware that that's why we teach so much, or spend so much time teaching communication now. Because it's so important to actually be able to articulate that. So when I did my training, I would tell the senior nurse, who was also a student, maybe only a year extra time than I would, who then might tell the new nurse that's just got their registration, wearing their brand new white uniform, historically as they did, then that person would then, it was such a linear hierarchy, which really delays it.
Yeah, and that's big time.
And that's some other research that we've shown.
Yeah.
That we've compared the research in private hospitals where, there's at one level less hierarchy from medical staff because they don't have junior doctors on the wards. Mm-hmm. So the nurses would report directly to the consultant who could make a decision quicker. If they could get onto them. But in that situation, it could potentially speed up the decision making, whereas in a public hospital, the hierarchy is such that the nurse will report usually to the very most junior medical doctor who may have even just arrived on the ward.
Yeah, who's still slightly got training wheels on.
Who hasn't even been out of university a month, and they're making decisions. And so then they will go to the person above them, who's the registrar, who then, if it's still not able to solve the problem, will then go to the consultant.
So time's still being lost, isn't it?
Yes. So, we have to be able to, and that's the other thing with these medical emergency team calls now, we're not only putting in what are the criteria for calling, but also time limits. So if someone doesn't respond in a certain time limit.
So if I don't ring you back and I'm your senior?
Yes, you can go to the next level.
Okay.
So, these are the system changes that have occurred, and these have all been happening.
Is this through your research or various studies?
This is various studies. We've just finished an NH&MRC funded study.
Can you say NH&MRC?
So National Health and Medical Research Council, which is our peak body for funding medical research in Australia. Yep. And we have been able to work closely with nursing staff and getting them to recognise not the subtle changes but also the vital signs and that escalation. But we've also worked with them on how they communicate with people and who they communicate to.
Right.
In order to make it happen faster.
Yeah.
And, you know, our results are just being finalised at the moment, but the preliminary results are looking quite good for preventing these areas where there is a breakdown in communication because of the systems.
Yes.
But also empowering nurses enough to, you know, go the next level.
Yeah.
Challenge thinking, because sometimes if you're working with the most junior medical staff and it's reported to them, they don't recognise the importance of the information they're being given, so can just sit on it. So it's important in the communication that the nurse is able to stress that importance and also, you know, informing. And that's why a lot of nurses go to senior nurses, because they don't hold back in then addressing, the, you know, working with the consultants or other levels of medical staff, because they are experienced and they recognise, you know, they've been exposed to these events so often.
That's right.
They recognise the urgency.
Yeah.
So they will say, oh, no, we need to get onto that.
Yeah.
You can't say, come back in 4 hours and I'll check it out. That's not good enough. We've got to call the consultant now.
Yeah.
So that's the kind of thing where we're trying to work with the systems
researchers.
And So, but look, this is a wonderful story of change in practice and in systems that has been really well supported by research, changing a whole system. You know, it's
shows the impact of research.
Yeah, it's an amazing story. And the Australian Commission of Safety and Quality in Healthcare has recently done a review in looking at how the standard that they put in place back in 2011, now it's, you know, at 2018 they did the evaluation and how positive it was looking on how we'd made those hospitals safer because of these systems.
And you're seeing the data, the figures of people coming back or things escalating and not being able to temper that have gone down.
Yes. We're trying to, very much you can start seeing the improvements.
That's awesome.
So we're seeing particularly people are not dying in hospital from cardiac arrests, which is the end point of someone not recognising what's going on. And the graph looks very much going downwards, improving. And in
the space of how long was that? 6 years, did you say?
Well, since this study, this type of work has been going since 1990. About 1995, the first Australian study was published.
I see, yeah.
So it is, you know, we're looking at over 20 years of work.
Yeah.
But in that time, a lot of people have been saved when you look at the numbers of 11 million going into hospital every year at this point.
And we have to finish now, but there's obviously many, many reasons why this research and these changes are profoundly wonderful for society and all of us individually. But I think anything that, as an end result, means that people can die or have more time at home, that's big. Because and people don't, we don't have enough discussions about how do we make sure that that's not us or it's not our loved ones that ends up, dying in hospital, as much as there's wonderful people working there. It's not where most people want to be, I don't think, is it? Yeah. Thank you for the wonderful work you do.
Thank you.
And I've really loved this chat.
Thank you for having me.
Thank you. Thanks for joining in the conversation with us about our healthcare system. If you'd like more information on any of the topics or researchers in this series, simply head to iht.deakin.edu.au.